Thank you, sir. I'd like to thank the ISG, in particular Professor Saraswat and my friend Dr. Govind Makharia for giving this opportunity. I'm sure that these activities started by ISG will definitely benefit all the students across the country. So I'm happy to start first webinar today that we are discussing on the current management of acute pancreatitis. Now, briefly, if you see all across the country, most hospitals in the gastroenterology, one of the commonest indications for admission, hospitalization is acute pancreatitis. In fact, in a couple of years back, there was a report from US that this was the commonest indication for hospital admission across US under gastroenterology. So the outline of my talk would be basically focusing on the management within the first 72 hours, within the first week, second and third week, and fourth week and beyond. And the reason that I'm emphasizing about the management in different time periods, you will see subsequently, is very important to understand. But these are not rigid boundaries, but this will give you an idea how do we manage these patients. Now, the first description of acute pancreatitis was given by a Dutch anatomist, Nicholas Tulp, in 1652. The incidence varies from different countries, anywhere from 30 to 100 per 100,000 population. If you look at the mean age of patients, this is somewhat younger in India compared to Europe and North America. It's about 40 in India. This is based on a recent study published in Gut. Actually, this is online, published in November last year. And if you look at the male, female, it is around 50% all over the world. In India, the report was around 70% males. The etiology is gallstone, as you know, in 40 to 45% of patients. Alcohol, quarter of patients. Post-ERCP is fortunately less, but still accounts for 5% in centers which perform a lot of ERCPs, but idiopathic is around 25%, where we really don't know the cause in the beginning itself. So how do we manage these patients? And let me take you first to the initial period of acute pancreatitis when a patient is admitted with us. Now, this is the typical clinical scenario of a 55-year-old lady comes with abdominal pain for about a day. Pain is quite severe. She has vomitings. Her amylase is 740. Her X-ray of the abdomen is normal. And I want to emphasize here for the students that whenever you see a patient with acute abdominal pain, you must get an X-ray of the abdomen done in the casualty itself in all patients, regardless of what you think is the likely diagnosis. So X-ray of the abdomen was normal, the amylase was high, and rightly the diagnosis of acute pancreatitis was considered. Ultrasound shows a bulky pancreas, small fluid collection, peripancreatic and gallbladder stones. The liver function test showed bilirubin of 1.8, SGPT 260 units. So the diagnosis was acute pancreatitis may cause biliary pancreatitis. Now, I want to emphasize here that whenever you see a patient with acute pancreatitis, if the liver function test is abnormal within the first 24 to 48 hours, you are dealing with gallstone pancreatitis, even if you do not see stones in the gallbladder. On the other hand, if you have stones, but your LFT is absolutely normal, etiology may not be gallbladder stones. For example, a patient with alcoholism, chronic alcoholism, comes with acute pancreatitis. He also has gallstone. How do you decide which is the likely cause? It is the abnormal LFT which will tell you it is biliary or otherwise. Now, in some patients where you consider microlithiasis as the cause because you have not found any cause, patient has recovered, he comes back for follow-up, you think it could be microlithiasis. Now, the best test to say it is microlithiasis is, again, go back to the records and find out if the LFT was abnormal in the first 48 hours or not. If it was not, it is very unlikely to be gallstone induced. Now, in this patient, CT was not done. And as you would understand, you all know that CT is not required for the diagnosis unless there is a diagnostic dilemma. That means you're not sure what you're dealing with. Otherwise, CT to determine whether or not it is necrotizing pancreatitis or it is severe pancreatitis is not really required. So what are the things that come to your mind on day one? One, if you are functioning in a peripheral center, when do I refer this patient? What analgesics to be given, because the patient's main symptom is pain. He's nil by mouth, he has got pain, he needs IV fluids, how much and what to give. If he has gallstone pancreatitis, do I need to do ERCP? When do you do a CT? I told you not to do a CT in the beginning. Does he require antibiotics? And how about his nutrition over subsequent days? So the first question is, when do you refer a patient? You're sitting in a primary care or a secondary care, you don't have facilities for managing sick patients. Two things will tell you. If a patient has SIRS, systemic inflammatory response syndrome, which is persistent for say more than 24 hours, this is a patient who needs to be sent to a higher center. Or within first 2 days or so, patients develop signs of organ failure. Again, this is the patient who needs to be sent to a higher center. Very simple, easily measurable in any setting. So the first management problem is pain, and we need to give analgesia. We have two choices, either NSAIDs or opiates. The concern is with either of them is safety. NSAIDs may cause a little bit of renal failure and GI bleed, while opiates may cause ileus and respiratory depression. So there's not much data actually which analgesics to choose. And we did a randomized control trial published last year in American Journal, where we compared diclofenac, which is the most common analgesic used, with Fortwin, which is an opiate, pentazocine. And the reason we thought was that diclofenac being anti-inflammatory and analgesics, it might give us a better analgesia. So what we did was we randomized patients to receive either diclofenac or pentazocine 8 hourly, 75 milligram, 30 milligram. And we also provided injection fentanyl as a rescue analgesia through a patient-controlled analgesia pump. What we found was, surprisingly, that Fortwin, the pentazocine, was better in terms of providing analgesia and pain-free period compared with diclofenac. There was a couple of side effects in the diclofenac group, which we were not sure was because of the drugs, but overall analgesic effect was better with fentanyl, with Fortwin. So in general, my advice is that opiates are better analgesics in patients with acute pancreatitis. But if patient no response, you can add either IV paracetamol or IV diclofenac if required. The second issue is about analgesia, is about IV fluids. Once you have given adequate analgesia, which is very important, you consider IV fluids. Between day 1 and day 3 is this most important. Now, most patients are kept nil by mouth in the beginning. So they need fluids. So questions are, what is the usual fluid deficit in acute pancreatitis? As you all know, whenever there is a lot of inflammation, the fluid goes out of the vascular compartment. The second is, what is the rate and type of fluid replacement, and how do you guide your fluid therapy? So I'll spend a couple of minutes on this very important question, which is rather controversial. The first is, how much is the loss? Now, a very old study by Ranson et al., who is a very famous surgeon, he showed that the fluid losses in acute pancreatitis were 3.7 liters and 5.6 liters in mild and severe pancreatitis. And thereafter, many people recommended that patients be given anywhere from 5 to 6 liters of fluid every day in the beginning. Now, subsequently, another study about 5 years back, published from Spain, we showed the median fluid loss to be about 3.2 liters. And they showed the predictor of fluid deficit were younger age, alcohol, glucose, and SIRS. So how aggressive one should be? You give a lot of fluids or give less fluid. Now, there is a lot of confusion about this aggressive fluid in the literature. So there was a systematic review of 9 studies. We showed aggressive treatment group received about 4.5 liters of fluid in the first 24 hours, while non-aggressive was 3.5 liters. So it wasn't actually 6 or 7 liters. And various people use various strategies, anywhere from 15 to 20 ml of per kg bolus fluid, followed by 1.5 to 3 ml per kg per hour infusion. or for the next 48 hours or so, depending on the response. So which fluid to give? So normally crystalloids are given, either normal saline or Ringer's lactate. In a randomized trial of 40 patients, Ringer lactate was found to be better than normal saline. And one of the reasons was that normal saline can lead to hyperchloremic acidosis. And another subsequent study also confirmed the same. So in general, the recommendation is to give Ringer lactate rather than normal saline. So how do you monitor when you give fluids? So the goals that you have to keep in mind are that I need to keep a minimum mean arterial pressure of about 70. Okay, so patient comes in with hypotension, you give fluids. If he's fluid responsive, you're good. If he's not, then you have to give vasopressors. But initially, you have to give fluids. So my mean arterial pressure should be around 70. Hematocrit around 40 to 42. Some people very rapidly dilute the hematocrit. That's not a good idea. And I want a minimum urine output of 0.5 to 1 ml per minute. That's my goal when I have to give fluid therapy. How do you measure whether you're doing a good job or not? So central venous pressure, which is generally placed in most of these patients, is not a good guide, especially those who are on ventilators. You may have stroke volume or arterial pressure, but again, this requires intra-arterial line, which is not done in most patients. But I would suggest that non-invasive measurement is very important. IVC diameter, and also I would emphasize lung ultrasound. And in most ICUs now, a bedside ultrasound is available. This is a video taken in our own ICU. You have a bedside ultrasound. You can easily, all the residents can easily measure the IVC diameter by doing a bedside ultrasound. And this can tell you whether or not there is fluid deficit or patient is fluid replete. The second that I would advise is that all residents who are posted in ICU, actually we have our resident posted in ICU, they must learn lung ultrasound, which is not very difficult. What you're looking for is some kind of B lines here. If B lines are present, this patient is likely to have fluid overload. If you do a 2 or 3 day course, you can easily learn a lung ultrasound, particularly those who have been doing abdominal ultrasound. So what are the effects of fluid therapy? If you look at some of these studies, they showed that they favor aggressive, that means more fluid, that if you give less fluid, there is more SIRS, organ failure, mortality. But there are many studies now, including randomized trials, which have shown that aggressive fluid resuscitation may itself lead to organ failure, increased abdominal pressure, more need for ICU care, and mortality. This study was published actually early this month from Latin America, 88 patients randomized who presented after 24 hours. So in most tertiary care centers, patients will present after 24 hours. So this becomes important for most of those centers. They randomize patients to non-aggressive, 1.5 ml per kg per hour for 24 hours, versus aggressive, that is bolus or 20 ml per kg plus 3 ml per kg per hour. And then in both the groups, 30 ml per kg for next 24 hours. And they found that mean volume of fluid infused in the aggressive group was 8.5 liters versus 5.1 liters over 48 hours. So per day here was 4.2 liters, here it was 2.6 liters. And they found no difference in SIRS, necrosis, organ failure, or hospital stay. So the point here is that in most patients who present to you, the general recommendation is to give about 3 to 4 liters of Ringer lactate in first 24 hours. And this should depend on fluid assessment and severity. We should have caution in patients who are elderly, cardiopulmonary disease, intra-abdominal hypertension, or renal failure. And beyond 3 days, you have to give fluids as per the output of the patient. So this is about the fluid management. Now, this is day 2 to day 4. The patient is febrile, counts are 14,000. PaO2 or FiO2 ratio is 280. Normally, it should be around 400 or more. It is 280. That means patient has grade 2 respiratory dysfunction. Creatinine is 2.4. Again, there is renal dysfunction. Bilirubin now has come down, 1.1 from 1.8, and SGPT is again come down by half. Blood or urine culture, sterile, small fluid collection seen on ultrasound. So what are the concerns on day 2 to day 4? When I have given analgesia, I've started the patient on fluids, what do I do now? So the first concern here is the organ failure. This patient has 2 organ failures. She had some abnormal LFT, may have biliary obstruction. Do you need to do ERCP or not? So I'm not going to dwell on this in detail, but ERCP is recommended only if patient has cholangitis. It is sometimes very difficult to assess there is cholangitis or not, or if there is increasing bilirubin. So in patients in whom you find LFT is improving, there is no reason you should do ERCP. One of the questions I just saw on the chat was whether to put stent in the bile duct or not. So most patients will not require ERCP because most of the times what happens is that the stone passes out on its own within the first 48 to 72 hours. In those patients in whom you have to do ERCP for either cholangitis or increasing bilirubin, you have to put a stent, okay? So that you leave till patient undergoes cholecystectomy. So the third concern here is prevent infected necrosis, and fourth is nutrition. So for organ failure, patient has to be in ICU. This patient was managed in ICU. Prediction of organ failure is difficult, but I showed you in the beginning, if a patient has persistent SIRS for more than 48 hours or so, he has high likelihood that he might develop organ failure and severe acute pancreatitis, because it is the persistent organ failure for more than 48 hours that defines severe pancreatitis. And these patients have very high mortality of 30 to 40%. And as of today, we can only provide supportive treatment. The next issue is whether we should give prophylactic antibiotics to prevent infections in either of these groups: mild acute pancreatitis, severe acute pancreatitis, necrotizing pancreatitis, and is there a problem with prophylactic antibiotics? Now, multiple RCTs and meta-analyses have been done, and they have shown no benefit of giving prophylactic antibiotics, except one study from Japan, which showed very early antibiotics may have some possible benefit, but most people recommend not to give prophylactic antibiotics. It is another matter, though, that most of these patients do receive antibiotics. When they are present to a tertiary care center, we found in a study, multi-center study, about 2/3 of patients had already received antibiotics. Now, sometimes there is a sense of false security that if you give antibiotics, you will decrease complication, but this is not done. Today, it's a litigant society now. If you give antibiotics, the patients are going to read in the literature that antibiotics should not be given. And suppose something happens to the patient, they might actually take you to the court and say, why did you give these antibiotics? Because the problems here are leading to more resistant infections, gram-positive infections, and of course, fungal infections. The next issue is about nutrition. And so when do you start nutrition in mild and severe? Does the timing affect the disease course? So one of the questions on the chat was, do you keep the patient nil orally? So most patients are kept nil orally in the beginning of the illness, started on IV fluids. And as their pain starts decreasing, then we think about the nutrition. This is recommendation based on IP guidelines I'm giving you. So oral feeding should be started in mild pancreatitis where there is no organ dysfunction as soon as the pain starts subsiding. Now, this takes about 2 to 3 days, and this time period is okay. There was one randomized trial published in NEJM about 3 years ago from Dutch group, which showed that very early, within 24 hours of enteral feeding, was not beneficial. So you can wait for 2-3 days without any problem. And this is strong agreement there. Enteral tube feeding should be the primary therapy in patients with either severe pancreatitis or those who are predicted severe. Now, there's a little bit of a difference between these terminologies. So predicted severe is where you think patient might develop severe pancreatitis. Severe means organ failure. So as of today, suppose there is no organ failure, but he has persistent SIRS, you think he's a patient who's likely to develop it. There you can start enteral feeding through a tube. Now, in these patients, you can give it either by nasojejunal or nasogastric, but nasogastric is easier. And there was a study done from our department by Dr. Raya, which showed that nasogastric tubing is as good as nasojejunal. The only problem is many of these patients cannot tolerate nasogastric feeding. And in that case, it is better to give nasojejunal tube. So final recommendation would be initiate enteral feeding as soon as possible, usually within next 3 to 4 days after the onset of disease. We prefer oral and enteral feeding, preferably nasojejunal in those with severe. Polymeric feed is given. Elemental feeding is not required. Our goal is to provide 25 to 30 kilocalories per kg with 1.2 to 2 grams of protein. But if you are able to manage about 1,000 calories in the beginning, it is okay with us. And we rarely rely on total parental nutrition. So these are the learning points in the first week of illness with regard to the management. First few days are critical. Adequate optimum hydration must be provided. Opioids are better analgesics for pain relief. There are early enteral nutrition is important, and we don't need to give prophylactic antibiotics. ERCP is infrequently required in these patients. Now, what I'll do is I will see if I have some questions related to the first part of my talk, and then we'll move forwards. So I have covered some of these questions, which were with regard to the nutrition and ERCP. There was one question on ERCP. If there is a quick question on any of these in the first week, I can take it. Dr. Saraswati, if you can hear my voice, if you have any question the first week, I'll like to take it up now.
Well, I think there's a flood of questions, Pramod, over about, I've got about 45, 50 questions already on. I think first ones you have covered, which are the ones who need to be kept nil.
Yeah.
And I think diagnosis of cholangitis during acute pancreatitis was another one, whether EUS will have a role, and also how do you diagnose in the presence of SIRS?
Okay. So first of all, EUS has no role in the beginning. It is the LFT which should guide. I have seen one question that if there is a patient with CVD stone but improving LFT after 3 days, my suggestion is to wait and do ERCP as you would do in a patient with CVD stone, regardless of pancreatitis. So if patient is improving, don't do ERCP because you might cause complications. There is one question about proton pump inhibitors. So generally, it is not recommended to give proton pump inhibitors. There is actually one study which is going to come from China, which is showing alteration in duodenal microbiome by proton pump inhibitors. So that should not be done. There are two questions about ulinastatin. So as of today, we do not have enough evidence to recommend use of ulinastatin for treating predicted severe or severe acute pancreatitis.
Analgesics during the first week. I mean, you talked about your study, but people were asking whether tramadol or whether it can.
Right.
And opiates, whether they can in biliary pancreatitis cause a problem.
Sure. So there is another RCT published from PGI Chandigarh where they have compared diclofenac with tramadol, and tramadol was found to be as good as other analgesics. So among opioids, tramadol is a good choice if you have tramadol available. But my recommendation would be opioids rather than NSAIDs. There was another question about this cholangitis. How do you diagnose cholangitis? So in a patient with acute pancreatitis, if there is persistent abnormal LFT and your enzymes rather than decreasing are increasing, and there is fever and leukocytosis, suspect cholangitis. Because in acute cholangitis, your SGPT and SGOT will keep rising. So that's an important point. But I tell you, it is difficult. So if you're in dilemma and your LFT is not improving and you think there is obstruction, go ahead and do ERCP, no problem. Okay?
About the IV fluids also, there was a question about whether colloids like albumin can be used in the first week instead of just crystalloids.
Okay. So some people have actually used colloids like albumin, a 5% albumin or even a 20% albumin, but there is no recommendation to give colloids. What you can do, use your judgment, like you do in critical care patients, that suppose you want to give fluids and patient is showing signs of fluid overload, or there is a lot of edema coming in now. That means there is vascular problems, more fluid going out of the vascular compartment. Then you may give colloids in form of albumin. Okay, so let me now go ahead.
Yeah.
In the meanwhile, you can see if there are questions. I'll take care of.
Sure.
Okay. So now patient is entering the second week, and this is the time when you have to now consider other issues. So the concerns in patient with second and third week, and these are the patients who have either moderate or severe acute pancreatitis. Mild pancreatitis will improve within a week or so. You really don't have to worry about those patients. So the concerns here are that is organ failure improving or continuing? Are you able to maintain nutrition or not? Is there now fluid collections coming up? Is there infection? Because this is a time when patient might develop second infection. Does the patient require antibiotics now? Because we have not given earlier. And how do you manage these fluid collections and infection? So nasojejunal feeding was started in this patient. SIRS was continuing, but the creatinine came down to 1.4. So there was improvement in her organ failure. PaO2 FiO2 ratio also improved. Again, there was improvement with this. So we are happy with that. If there is no improvement, you got to continue them in ICU, and many of these patients may require hemodialysis or ventilator support. We are currently doing a study where seeing whether NIV can help tide over the crisis in those who may ultimately require ventilation. Now, this patient, we found there was a collection developing on ultrasound about 10 centimeters, and patient continued to be unwell. So if you have persistent organ failure, I told you very high mortality, and most of the times, those who are going to die will die within the first 2 weeks. So more than 50% of deaths occur within the first 2 weeks of illness. And when we discuss about infected necrosis and pseudocyst and walled-off necrosis, we often forget about those patients who have died in the early course of the disease. And these are the patients who require more attention, okay? So we all happy doing a cyst drainage, but I think the emphasis must be placed on those who have severe disease and organ dysfunction. So for nutrition is critical now. Why? Because these are the patients who are going to have a prolonged battle. They are not going to improve soon. And again, as I said, our target is to provide about 1,500 to 2,000 calorie diet. And if you have not placed a nasoenteral tube, please do so in the second week for sure. So the next is fluid collections. Is infection developing? Does the patient have necrotizing pancreatitis? We have not done a CT. Does the patient require antibiotics? And how do we manage these patients? So in this patient, now you do a CT because patient is unwell, there is fever, there is high counts. We need to know what is happening. Are there collections? So if you find a collection and there is necrotizing pancreatitis, two factors will determine the outcome: the amount of necrosis and the size. If the necrosis is more than 30%, or there is significant peripancreatic necrosis, or the size is large, they're likely to persist rather than resolve. So should we drain if there is a sterile fluid collection? Patient's fever is minimal, counts are okay. There is some unwell, patient is little unwell, SIRS may be plus minus. What do you do? So there was one RCT of 40 patients with sterile fluid collections randomized to conservative treatment versus catheter drainage. And the authors found that in conservative group, 55%, about half of them required drainage later on. But 55% of patients who underwent catheter drainage in the beginning developed infection, although the first culture was sterile. And in the conservative group, 45 improved without intervention. So another study also showed about 60% patients developed infection following drainage of a sterile collection. And that is why most guidelines suggest that patients in the second and third week of illness, if you have sterile fluid collection, conservative treatment should be done, and drainage should be done only if they are symptomatic. Now, if fever is continuing and counts are rising, now you suspect that there is infection. So earlier we used to do a fine needle aspiration cytology, but our own experience and other experience from other centers showed that FNA to diagnose infection is not really very important in such a situation, because you have to act now because you're suspecting infected necrosis. So question is, do we drain or not? Does she require necrosectomy? So first is antibiotics or not. Surely in this patient, his fever is persisting beyond first week, or there is an onset of new infection, new fever, and TLC increasing, it's prudent to start antibiotics. Now, serum procalcitonin may be of help at this stage. So there was a question related to procalcitonin. So in the first week of illness, we have seen in a study that procalcitonin is also raised even without infection. And that has been seen in other studies also. But if you are in the second or third week, you suspect infection, a rising procalcitonin or a high procalcitonin is a good guide that patient is likely to have infected necrosis, and you should start antibiotics. Which antibiotic will depend on your local culture sensitivity. For example, in our hospital now, most patients have resistant infections, so we start them on right away with either piperacin tazobactam or cefepime-sulbactam. That's our first antibiotic, because otherwise they have resistant infection. If fever persists, you're not happy with one antibiotic, you suspect Pseudomonas infection, then we can give second antibiotic, but usually we give one in the beginning on empirical basis. And most patients will require a CT where you can see large areas of pancreatic and peripancreatic necrosis. And sometimes you have extensive necrosis and extensive inflammation in the abdomen, like in this patient. So you have to decide, what do you do now? And next question is, drain or not? Mind you, we are in the second and third week of illness, not beyond that. So should we drain or not? Now, there's not much data about draining in the second and third week of illness. So the guidelines published 2013 showed invasive intervention, including percutaneous, where possible, should be delayed until at least 4 weeks for collection to walled off. So guideline would say wait. So so right now there is no randomized trial. There was one retrospective study published from Netherlands of 117 patients, in whom they found some of these patients had gone early drainage, some drainage after 4 weeks, and they found that there was similar hospital stay and mortality, but the need for necrosectomy was somewhat less in early group. So the Dutch group is conducting a randomized trial in such patients, and we are also doing a randomized trial of early versus late percutaneous drainage in patients with deteriorating condition in the second and third week. So the message here is, if your patient is deteriorating and continuing to have fever on antibiotics, you should drain. This patient underwent drainage and antibiotics and then improved. So this is the summary of my talk in the second and third week of illness, where it's a period of basically waiting. You don't have to do intervention in most patients. They require maximal ICU support. Conservative therapy is the norm. Nutrition is the key. And if there is organ failure or sepsis is worsening, we may be required to drain the collection that you have. And for this, you need to do a good CT, and drainage should ideally be done under CT guidance. Okay. So I'll again see if I can take some questions because before I proceed further. Dr. Saraswat, if you are there, you can see if the question I have to answer now.
Oh, sure. I think just give me a sec. Yeah, there seem to be a lot of questions as usual. I think we have crossed 100 or maybe, I don't know, 100 plus by now. So now, one question is there a role for CT-guided aspiration in the second week to rule out infected necrosis, or patient should be started empirically on antibiotics with the suspicion of infection?
So in general, the role of CT-guided FNA is now given up. If you strongly suspect infection and patient is not improving on antibiotics, my suggestion is to drain. So we generally wait for about a week or so and see the effect of antibiotics before we plan drainage. Otherwise, it's not recommended now to do FNA. Okay.
Yeah. Okay. So this is the other thing was, I think, going back to your earlier question about analgesics and feeding. One question was, do patients have to be pain-free before you start enteral feeding, or a mild pain? With mild pain, you can start enteral feeding? So
mild pain we can start, but it depends on patient's tolerance. If patient is able to tolerate soft liquid diet, about 500 calories or so, this is fine. And gradually increase as per patient's tolerance. You don't have to force feed the patient. That's very important. One of the questions I was seeing is about TRCP versus MRCP. I think only when you are really, unsure, you may do MRCP. Otherwise, don't do MRCP in these patients who are sick. So if LFT is improving, wait. Okay.
Right. Coming back to antibiotics, I think there were a couple of questions on that also, which if you can take right away.
Yeah,
so
sure.
One was if there is a coexisting infection like in the chest or the lungs and in severe acute pancreatitis, what antibiotic or would you start antibiotic?
So yes, so whenever you have a patient with suspected infection, that means you are in the second or third week of illness, patient is running fever, counts are rising, you suspect infection, even if it is non-pancreatic, you must start antibiotics. And in a study done many years ago, we found that actually more than a third of patients have non-pancreatic infections, so they need antibiotics. So shall I proceed for the next part,
just
which will take about
1 second. One was mentioned about people reading guidelines and then maybe suing doctors for using antibiotics inappropriately. This is a question riffing on that, which says that if a patient has high TLC fever, later on goes to develop sepsis, in the second week, can't he be sued for, doctor be sued for not starting antibiotics in the first week?
Yeah, sure. But you can obviously, quote studies which say that in the first week, the fever and rising TLC is because of the illness itself, not because of infection. This is a sterile inflammation which leads to that. So don't worry about that. There's enough literature to support you in the court.
Right.
And if patient has to take it, he will take you anyway. Don't worry.
Okay, go ahead.
Okay. Yeah, sure. So now what happens that most of the patients, like I showed you, may improve if they are not very sick. Their organ failure has improved. If there is infected necrosis, you treat with antibiotics, and if required, percutaneous drainage. But antibiotics must be given at least for 2 to 3 weeks. Sometimes we have to give it for 4 weeks. So it depends on how much infection is there, how the patient is responding. Okay. But there are patients who will not improve, who will continue to have problems. And we are in the 4th week and beyond now. So what happens? These are the patients who have definitely suspected infected necrosis. So fever may be continuing. You have rising counts like this. So there are two situations. You have already placed a percutaneous drain, or you have not placed a percutaneous drain. And I'll take up both next subsequently. So the question is, does the patient require necrosectomy in the 4th week onwards or not? So we did a comparative study published many years ago, because we found many of our patients who had confirmed infected necrosis actually improved without necrosectomy, because necrosectomy was the norm at that time. And we found of 80 patients, the survival in those who were treated medically was 76% versus those treated surgically, where it was only 46%. And mind you, this is the figure seen all over the world. And we found that medically managed patients had better survival. It is quite possible that those who had undergone surgery were more sick patients. But having said that, the idea here was that we can treat patients with infected necrosis even without the need for necrosectomy. So we did a systematic review and meta-analysis of 8 studies which had looked at this issue of infected necrosis. Do they require necrosectomy or not? And we found that with or without percutaneous drainage, there was 64% success rate. 70% patient required catheter drainage. The requirement for necrosectomy was only 26%, with a mortality of 12%. So this reaffirmed our belief that there are patients with infected necrosis who can be treated without necrosectomy. And this has been subsequently, results of many other studies. So this is the step-up approach recommended by most societies and guidelines. Conservative treatment first, followed by percutaneous drainage, and followed by minimally invasive necrosectomy if patient doesn't improve. So everybody wants a patient like this who has got a large collection, walled off, just opposite the stomach, very well-formed wall, patient is stable, no organ failure, and now everybody wants, let me do endoscopic drainage and necrosectomy. Sure enough. That, granted, you can do that. But often you have to make sure that how much is the debris inside before you jump in. So ultrasound can show you a lot of debris inside in such a collection. MR, of course, is better. We showed you large areas of necrosis within this. What looks like a pseudocyst is actually a walled off necrosis, a lot of debris here. The black area is the debris, the white is the fluid here. So you have to do ultrasound and if required, MRI to determine you're dealing with pseudocyst or you're dealing with walled off necrosis. Most of the time, you will be dealing with walled off necrosis. So if necrosis is required, this is a study from AIG Hyderabad, Sandeep Laktekia publishes endoscopic step-up that of 205 patients, he showed successful drainage with 75% patients, 9% required necrosectomy. The 2 RCTs have been published. One is tension trial, the other is Miser trial. Both showed that endoscopic step-up therapy is feasible and equally effective with lesser complications. So both these studies had patients who had large collections, which were well-formed. And you can see this is a busy slide, but the overall mortality was around 18 and 13% in the tension trial, but less than 10% in the Miser trial. And these were patients who had infected necrosis. So in such a patient, you can surely go and do a standard endoscopic drainage. And today, the standard therapy is EUS guided drainage. You can either place a plastic stent or a metal stent. So if you have less than 1/3 of necrotic debris, you can easily place plastic stent. Otherwise, if you have a stable patient the collection that I showed you, very well formed, it is better to place a metal stent like this, which provides better drainage. The other advantage of a metal stent is that it's easier to enter the cavity subsequently for doing lavage of the cavity if the fever persists, and also if required necrosectomy. So you can do necrosectomy through the stent very well. Sometimes there's a risk of stent migrating out, so one has to be very careful doing this procedure. And my recommendation is not to do necrosectomy in the index procedure. You have to wait if patient improves, and majority of patients will improve, and that they will not require necrosectomy. Now, if you have placed a plastic stent for drainage this wall of necrosis, and patient develops infection or they don't improve, you can see here there's a patient with no plastic stents were placed. You have to go inside again. Now dilate this tract to about 15 millimeters with a CRE balloon, and then you can see pus coming out of that cavity, and then you have to enter this cavity with the help of a standard upper GI endoscope, and then lavage the cavity. So in the beginning, what we do is we only do lavage, and only later, when patient is stable, we do necrosectomy. Because necrosectomy will take time, and many of these patients may require intubation, and you have to do the procedure under general anesthesia. So with lavage alone, many of these patients will improve after with your antibiotics. Okay. So sometimes you can do it in one sitting, sometimes they require 2 or 3 sittings. And then you see the cavity is almost clean and patient will be fine. Now, one thing I want to emphasize is about these tension and MISA trials, because these are the 2 trials everybody talks about. These are the patients, in those 2 trials, patient infected necrosis were treated, but they were stable patients. Mean duration of drainage was about 6 weeks. Most patients, 90%, had walled off necrosis, and they were all suitable for endoscopic drainage. Now, sometimes when you don't read the literature well, you will feel, oh, everybody with infected necrosis can be treated by per oral endoscopic. You just place a metal stent and everybody will be fine. That is not the case. You have to judge what kind of patient do you have. Is the patient sick? Is the patient ICU? Is the patient having organ failure? Is the collection suitable for drainage or not? So many factors have to be taken into account. So patient ICU, organ failure, or conservative treatment is going on, and you have placed a percutaneous drainage already. Now, if you have placed a percutaneous drainage, patient is not improving. First of all the fluid has gone out. It is extremely difficult to do per oral drainage and necrosectomy in these patients. Most of the time, you have to do what is known as minimal invasive necrosectomy by ward. So, for example, or you have a large collection like this, which is much away from the stomach. You can't do a per oral drainage. You have extensive necrosis, again, much away from the stomach. You can't do per oral drainage here. And you have placed a stent like this. So, for example, this is one of our patients in whom large collection was there, a percutaneous drainage was placed. So what do you do in this? So what we do is to do what is called as percutaneous endoscopic necrosectomy. But most of the time, majority of centers, what they will do is to do a minimally invasive surgical necrosectomy. And I think that's a perfectly fine treatment for these patients. So patient with percutaneous drainage, not improving, next treatment is minimally invasive necrosectomy. It can be done surgically, and they can use either a ward or a nephroscope can be used, and most of the patients will require just one sitting. Sometimes they require multiple sittings if they have a complication. So using the same technique, the track of the percutaneous drain, we do percutaneous endoscopic necrosectomy. So we dilate this tract to about 12 millimeters and then use a regular upper GI endoscope for lavage and necrosectomy. So you can see this one patient had multiple drains here. It is we are doing at the bedside of the patient. This is the ultra thin scope which is going through the same track for lavage. And here is a patient in whom there was a large collection and necrosectomy. So you dilate this track and use a upper GI endoscope to enter the cavity, much like you do in per oral endoscopic necrosectomy. Do a lavage, take out the necrotic debris using either a basket or a snare. Snare generally is the most commonly used. And then you find that in 2, 3, or 4 sittings, the cavity may become cleaner. Now, I want to caution you here that first time, don't try to do necrosectomy. What we do is to do just lavage. And once the patient is stable, then only we try necrosectomy. And lavage alone, when you take out all the debris from inside, the thin debris and all the pus-like fluid, the patients improve. So this is a procedure which can be done in your endoscopy theater under conscious sedation. Okay, and this can be performed by those who are experienced, but you have to be very, very careful when you do such a procedure. So this is how you can take out small debris. Sometimes you take out large debris, but that is uncommon. And the cavity looks like this after you have drained. So we published our results in 2015 of only 15 patients, but subsequently we published results of 53 patients who underwent percutaneous endoscopic necrosectomy, 84% improved. 8 of them died, 5 after surgery, and 8 had complications, 2 peritonitis, both improved, 2 had bleeding, 2 had fistula. So this is a procedure which is something like minimal invasive surgical necrosectomy, and it can be done. So the current recommendation is in patients with infected necrosis, conservative first approach for infected necrosis, and minimal invasive necrosectomy if there is no improvement. But the problem doesn't end here. You think if you take out all the debris, you do necrosectomy, you treat the patient in ICU, they will all improve. That's not the case. And we published a study in 2018 of 209 patients with acute pancreatitis. Saransh, who was with us at that time, he published this study. Mortality was 22%, and we found that independent predictors of mortality were organ failure, which I've already shown you. And the other problem which is now coming up is MDR infection, very odds ratio of 0.4. So now our patients are all resistant to piplusin, tazobactam, imipenem, meropen, everything. And we end up giving tigecycline or colistin to these patients. So that's another major problem which is coming in these patients. There are many other problems these patients might develop. One is intra-abdominal hypertension, hemorrhage, either from the cavity, from a small vessel, or from a pseudoaneurysm, for which you may need to do a DSA and embolization, intestinal fistula, sometimes colonic fistula, for which they may require surgery, and infected ascites with multiple septae. Now, these are the problems which further complicate the course, may require other interventions, including surgical interventions, but time will not permit me to discuss these issues. But I can take up questions if there are some questions related to that. So where do we go from now? How do we improve the outcomes? So one, we need to develop therapies to target systemic inflammation. Unfortunately, we don't have any therapy available as of today, but people are working on that, and we might have something in the next 5 to 10 years. We need to bring down this issue of multi-drug resistant infection. This is coming up in a big way, and I'm sure many of you are seeing this problem. And please don't drain every collection that you see, otherwise you will end up introducing infection which wasn't there earlier. Okay? So the summary of my third portion of my talk is that infected necrosis, conservative first approach, conservative to PCD to minimal necrosectomy. You have to differentiate between pseudocyst and walled-off necrosis. If you have walled-off necrosis, which is symptomatic, you can do either endoscopic drainage or VAD. For stable patients, EUS-guided drainage is done. And if there is significant debris, you do place a metal stent. For infected, unstable patients, my suggestion would be percutaneous endoscopic necrosectomy or VAD. And we have to understand that this is a team approach. You have to involve your surgeons and your intervention radiologists right in the beginning. Otherwise, you won't be able to manage these patients well. So thank you all very much for your attention. I'll be happy to take questions now. Dr. Saraswat, sir?
Yes. A fantastic presentation, Pramod. I think, unfortunately, on these webinars, there's not much in the way of clapping and applause for the speaker at the end of the session. Yeah. But I think one index is that I think there are over 325 questions that have come in, and it's obviously impossible. You can spend the rest of the night trying to answer these questions.
So what I'll do is, sir, I'll take up some questions now if you have time. And the others, I will request the team to send me the question, and I will send the answers to all those questions. I'll do that.
That's absolutely great. So I think one of the questions that is related to the endoscopic drainage you are talking about was how many sessions of endoscopic percutaneous necrosectomy versus ward? Are there any data for effective for large collections?
So when we do per oral endoscopic drainage, what Sandeep has shown is that majority of patients you can get away without necrosectomy. So if you do a metal stent, you place a metal stent, most of these patients will be okay. You have to do lavage in some patients if they develop fever, if they have a running fever. Otherwise, less than 10% patient will require necrosectomy. This figure will vary. This may be 30%, 40%, 20%. As we accumulate more evidence, we'll tell you. But everything will be guided by patient's condition.
Response.
Yes.
So do you follow a protocol of looking at the response and then going in? So is there a limit to the number of times you want to go in, or
right.
it is only dictated by the patient's condition?
So it's patient condition which guides. But what we do is when we place a metal stent, within a week, we go back in, planned way, do a lavage, make sure that we have all the infected material out. We don't touch the necrosis, and we watch. If patient is doing all right, we do nothing more. We take out the stent after about 2 weeks. Our protocol instead of 3 is about 2 weeks. But if patient is running fever, then we will do necrosectomy. And we do necrosectomy on demand. That means we do it today, we'll do it after 2 or 3 days, till we find that there is no significant debris remaining there.
And about hydrogen peroxide during endoscopy?
Right. So we were early using hydrogen peroxide for this lavage at the end of the procedure, both peroral as well as when we are doing percutaneous endoscopic necrosectomy, but we have stopped doing now because in some of our patients, in fact, in this report, 2 patients developed peritonitis, and we thought that it could be because of the hydrogen peroxide. So we have actually stopped doing that.
Right. Another interesting question was, you're doing percutaneous endoscopic necrosectomy, and have you had the problem of a fistula or a persistent discharging sinus after percutaneous endoscopic?
Another important question. So most of the patients, there is no problem. So what we do is we downsize our catheter. So our size of catheter when we are doing necrosectomy will be 30 to 32 French. And then once we are sure that the cavity is clean now, we downsize it to 16 and then to 12. And then we place a Riles tube, cut it, and put a colostomy bag there. So some of these patients will keep draining some fluid for a month or even longer, but majority of times they do well. We haven't actually done ERCP for if I remember correctly, for none of these patients.
I see. And any experience with encountering portal vein injury or bleeding during necrosectomy? And then
so portal vein we have never seen, but we have seen bleeding in the collection. So during the procedure, one has to be very careful not to go if you see any visible vessel. In fact, it is better just to put some saline and come out. But we have seen hemorrhage within the collection in about 8 to 10% of patients who have undergone percutaneous drainage. And this is something that we are seeing more often. Maybe we are seeing more complicated patients, large areas of necrosis, infected necrosis, who have bigger size drains put in. So that is a problem. But one caution here is don't try to remove debris which is adherent, which is very important. If you try and remove the adherent debris, you will end up in problem.
Another question related to metal stents. Nagi stent, now you have the J-Mitra people with a stent, there is a Spaxer stent. Which one would you choose for?
So I would say that all these stents are similar. There is not much difference, except that if you talk about hot axios, the hot axios advantage is that it's a one-step procedure. You don't have to use other accessories and you can just simply place it. The only problem with that is the cost. And if the cost of the stent comes down, I would say that this would be a preferable stent. But as of today, the cost is pretty high. So I'm not sure that, this is the best stent. Right. My problem here is the cost.
And any experience with the pancreatopleural fistulae management?
Yes, so many patients may have pleural effusion. All of them do not have this fistula. Some patients may have fistula. This is more of a problem patient with chronic pancreatitis, not so much in acute pancreatitis. So if you have significant effusion, my suggestion would be to place a PCD there rather than repeated drainage. Just place a 8 to 10 French of percutaneous pigtail drainage and they will do well. Most patients do not have a persistent pancreatopleural fistula.
Right.
In chronic, yes, they might.
For the endoscopic large collections, we've mainly spoken about endoscopic drainage in various routes. How about standard percutaneous drainage? And the interesting question is it some way you can judge based on pancreatic or fluid amylase or other parameters whether the large collection has a communication with the pancreatic duct or not before you decide percutaneous versus endoscopic?
So first of all, amylase may help you, but in practical terms, it doesn't. Most of the time, you'll find the amylase is high. Most of the time, there is a communication with the duct. That's why they have necrosis and large fluid collections. So most patients, as I told you, in step-up therapy will undergo a percutaneous drainage, and only those who do not improve will require surgical necrosectomy. So, but if you have managed the patient well for 3 or 4 weeks, and after that you find, even in the 4th week itself, that there is a well-formed collection with well-defined wall, you can straight away go and do endoscopic drainage rather than placing a percutaneous drain, if it is, of course, suitable close to the stomach or duodenum.
Right. I think that for other large collections, paracolic, pelvic, is there any role for any endoscopic or percutaneous management?
Yes. So this is what I'd shown you, that for large collections away from the stomach, the standard is to place a percutaneous drain. We upsize this drain to gradually to 30 French. And once we find patient is not improving, you can either do a VAD, that is surgical necrosectomy. What we do in many of our patients is percutaneous endoscopic necrosectomy, as I have shown you in one of the videos.
Right. So just to move away from drainage, I think there are some interesting questions about the role of anticoagulants in splenoportal thrombosis associated with acute pancreatitis.
So I think another important question. So most patients, we don't give any anticoagulants. So the risk of developing portal vein venous thrombosis is about 10%. Majority of these patients have no problem. They may develop for splenic vein thrombosis, fundal varices, but multiple studies have shown that in the long term, they have no problem. If they have varicose bleeding, you can manage endoscopically. So there is no recommendation as of today to treat them during the acute episode with anticoagulants.
Right. Okay. Well, I think the other questions relate to the timing of surgical intervention. What surgery and when does the endoscopist feel that he has to refer to the surgeon and he gives up on endoscopic management?
So the timing of surgery is best after 4 weeks, or even better after 6 weeks. That is it. But if you are in a center where you don't have, expert endoscopists to do these procedures, my advice is to get the surgeon in very early. That 4 weeks onwards is the time when you have patient with infected necrosis, you have placed a percutaneous catheter, not improving. This is time to go in. Otherwise, they will develop low albumin, malnutrition, resistant infections, and then there will be problems.
You're right. So I think we still have a couple of minutes. So what I'll just roll back on the previous questions. And I think one of these was management of compartment syndrome secondary to increased intra-abdominal pressure in the first week. Diagnosing and what do you do about it?
Okay. So this is an important problem for which we really don't have much answer. So in the beginning, if you find the patient has intra-abdominal hypertension, the pressure is above 14 or 16 or 18 or developing compartment syndrome, see whether you have ascites. If there is ascites, drain the ascites. Put the patient nil by mouth. Put the patient on a nasogastric aspiration. These patients may require TPN. And if on your imaging you find there is a collection, then you can do percutaneous drainage of the collection even the first or second week of illness. Because here the problem is of the pressure and compartment syndrome. Some of these patients do not improve. They may require surgery, laparostomy, but it is extremely difficult and challenging procedure. So most patients, I would say, will require conservative therapy. Wait for some time. Again, the pressure gradually comes down. Once the inflammation subsides, pressure comes down. So nil by mouth, nasogastric aspiration, drainage of ascites, and drainage of any collection which is there.
Finally, I think we'll just take one last question. You have talked about fulminant acute pancreatitis in your earlier presentations at SGPG at AIIMS. And once there is rapid worsening of a patient, the question is there a role for ECMO, extracorporeal membrane oxygenation, in acute worsening patients?
So ECMO is something that we have not tried, and it is something like any other critical illness. If patient has respiratory failure to the extent that with full support there is no improvement, and you can try it. We haven't done that, but you can try it like any other patient.
Critically ill patient with
any other critically ill patient.
Need it. All right. I think we last 2 minutes of the live session according to my timekeeping. So I think, Pramod, I must really thank you. It's been a very educative experience for me in person, as well as I'm very sure for all the numerous people who have logged in for this webinar. The I think the question count is touching 400. So you'll have a full week ahead of you trying to answer, although there are some of them are repetitive questions.
So, yeah.
Yeah, before we sign off, I think I'd just like to talk to you about the next session. Sunday afternoon, Dr. Ajay Duseja, Professor of Hepatology, PGI, Chandigarh, will be talking about the current and emerging management of non-alcoholic steatohepatitis from 12 to 1. So all of you and your friends and family and anybody else who are in your touch are all welcome to come and attend, because NASH is such a common problem that all of us would like to learn to manage it better. With this, I must thank Pramod, Govind, and the entire team that has been supporting this webinar from the ISG Secretariat at the All India Institute. Thank you very much. And all the participants and the delegates, thank you so much for joining in such large numbers. I believe we crossed 1,500 delegates at some point during this presentation, which I am very happy and is an impressive number. Thank you very much.
Thank you, sir. I'd like to thank all the participants and ISG also, and I'll be happy to answer the questions. Thank you.
Great.
Great.
Okay. Sure.
Bye.